Welcome to For the Record. On this show, we talk about events and issues that are of interest to our local people. Today I have with me some people who are going to talk to us about hospice care. A couple of years ago, when I had the situation where a family member had come down ill and needed that kind of care, I had no idea where to go or what to do. So I have with me today some of our people who are going to tell us just what happens when somebody in your family might come down with a terminal illness. I have with me Irv Roulett, Mary Bavilacqua, and Elizabeth David. And Mary, perhaps you might start by giving us an overview of the kinds of services that hospice gives and what's involved in that kind of care.
Mm-hmm. Hospice care is care given primarily in the home for patients who are terminally ill. These patients choose to remain at home for the most part, although can return to the hospital if needed for some symptom control. And they are patients who the doctor and a physician is essential here, that a primary physician be in place for each patient, that he determines that the stage of the patient's illness is such that there is a prognosis of 6 months or less. And when these criteria are met, then a patient can receive many of the home care services which hospice provides, namely nursing visits once or twice a week, as often as necessary, 24-hour availability of a nurse to be called if there were an emergency.
Sometimes that can be needed too, I suppose. Huh?
Yes, oftentimes. It's difficult to keep people at home who are terminally ill, and most families do need support, and hospice is there to give that support. Any equipment that a patient might need in the way of a bed or oxygen, medications, all of these items are supplied for patients in the home setting. Medications can be delivered to the home if necessary.
Now, some could be done by the family themselves as far as administering medication, but I imagine some has to be done by either a registered nurse or a doctor.
Particular things might need to be given by a nurse if it were something that needed a licensed person, something that was injectable. Then a nurse would be required to do that. Many family members are taught how to do these kinds of things, to give injections.
Are they? Good. All right, so what would some of the other kinds of things be? I imagine you have some therapists that could be involved.
If necessary, if that's part of the plan of care, there are physical therapists who can help patients with muscle strengthening exercises. There are people who need a home health aide, someone who would be able to assist with a bath or give direct personal care, change linen, shampoo, back rub, those kinds of things. Home health aides are available for patients.
I understand there's a knack to lifting somebody out of a bed or transporting them.
Yes, there is. Transfer from bed to chair.
So these are the kinds of things that you would go into also.
We do work as a team, and the other services that are available would be visits from our social worker. She's able to help families and patient with any of the psychosocial, emotional problems that are prominent oftentimes at this stage of life.
Well, most of us are unprepared for what taking care of a sick person really means. You know, you think in terms of things as basic as being able to feed yourself, and suddenly that becomes an impossible thing for somebody to do. And it's amazing how much time it takes to feed another person. As you said, giving them a bath.
That's correct.
Even giving them a bath, I guess, must have its own special little methods. Do they have any, what shall I call them, any little wrinkles that they use to do those kinds of things? What's the kind of training that goes into some of these things?
For home health aid, our home health aides are certified, so they have gone through a period of training where they are taught how to treat patients very sensitively, as well as give personal care. They know how to give a back rub the right way, and many patients are prone to fractures when they are so frail that it's important to know how to lift or to transfer someone from a bed to a chair correctly, and family members are taught
how to do all of this kind of thing. Now, Elizabeth, you have people who augment some of this home care with the nurses and the therapists. What's your involvement in the hospice care?
Well, my tasks really are to recruit, train, and supervise volunteers. When a family is taken on, they are told about our volunteer services. The volunteers can go into the home to do respite care, that is to be with the patient when the family member needs to get out. We have volunteers who will even go out in on a Saturday evening so that if there's a couple involved with taking care of an elderly parent, they can get out. Our volunteers do transportation of family members and our patients to physicians' visits, that sort of thing. The volunteer is given the name of the family, and I usually will call a family in advance to make sure that we know what their needs are of a volunteer. And then the volunteer would call directly and make contact and go in and introduce him or herself and really just begin to get to know people. The training includes a lot of work on grief and loss and communication skills, particularly listening. If there's one thing that I can get across to people in this situation, it is to be a listening presence, really, for our families and patients. And they're also eyes and ears for our hospice team, because the volunteer, when placed, is in there probably the most often of anyone on the staff, with the possible exception of a nurse. And so that when there are concerns that a volunteer has, we pay particular attention to that, in terms of the psychosocial particularly.
Sure, because I can see where the professional might come in, do the job, and be on her way or his way to the next patient.
Yes.
But a volunteer, as you said, would be there for a little longer time and probably hear things, as you said, that maybe the professional staff wouldn't.
And we try to be very creative in placing volunteers, because often families aren't sure, well, what is a volunteer going to do for me? So we at first like it to be task-oriented, to do some errands, to get a bottle of milk, to do some driving. But of course, when you have someone in the car with you, it's like kind of a captive audience. And that's when you can get to know someone very well and maybe do some emotional support at that time, and some listening and some intervention. We do not do therapy with them. Our volunteers are not trained therapists as such. But in a way, it is like grief counseling at times, or simply a social kind of visit. Whatever the agenda of the patient and family is what we go by.
Now, Irv, you're one of the volunteers that works with the hospice. One of many. Can you give me a feel for about how many of you there are doing this?
I think that you better
I could
answer
actually
that.
answer that probably more readily. We have about 50 volunteers now. They're not all direct service. By direct service, I mean with the family. We have administrative volunteers who come into the office and relieve our administrators and sometimes other staff of chores. We also have a group called Friends of Hospice, which is our fundraising foundation. We have talent pool. Those are volunteers with a particular talent that they can do for a time-limited kind of thing. Like one volunteer was a caterer and will put up frozen meals for families. We had a volunteer who does massage, that sort of thing.
I'd sort of like his name myself.
It's a female.
Well, that is.
But I think Irv could tell us more about the details of the day-to-day routine of a volunteer.
How did you get involved in the first place?
I watched what was happening when my parents were busy dying. And because we are a large clan, we were able to have family members in the house. But we also dissipated my parents' money. And
Well, this probably
that just stuck with me so vividly. And when I discovered hospice, I realized that, boy, why wasn't it there in New Jersey when we needed it? And that's what led me into becoming a volunteer.
Because you had already experienced the need for it and knew how it was without hospice care. What are some of the things that you do now as a volunteer?
Well, I can tell you what I did this morning.
Okay. That's about as updated as we can get, isn't it?
This woman's husband died over the Christmas weekend. And this was my first visit with the widow. And I found her being very, very logical, which was different from my prior small engagement with her. But I realized that she was bottling up a whole lot of things. And in this first meeting with her, I was certainly not going to pop all that stuff out. Sure. I told her what I thought my role was. I encouraged her to call me anytime. I promised her that I would be calling her at least every other week, and that I would be wanting to come to visit with her at least once a month, and probably twice a month. Well, everything softened, and she cried a little bit. And
it's always a good sign.
Yep.
That,
Yep.
So just the fact that she had somebody to depend on, or rely on, or even knowing that you're there.
Another somebody.
Yes.
Yeah. Another somebody
makes a big difference.
Yeah.
So this was part of your being the listening ear, so to speak, and somebody to lean on, which I guess we all need one time or another, no matter how strong we think we are. Now, this was your most recent experience today, so you must have a couple of other experiences that you can tell us about.
Well, I've been a volunteer for 3 years. I've had 7 patients, 7 primary caregivers, is what I ought to say. The person who's really taking care of the
patient,
person,
sure.
That's my client.
All right, rather than the patient himself, herself, who would then probably come into play with the professional team, your major duty is really helping the family deal with
supporting that person who's doing the work.
Okay,
who
that's a fine point. That's true, that I probably might not have made that distinction.
If I may just interject
Sure.
here, it varies with each family. Sometimes the volunteer is more connected with the patient, especially if the primary caregiver needs to get out and there's no one else to stay at home except a volunteer with the patient for a block of time. So there's as many families and patients as we have. Those are the varieties of tasks that the volunteers perform. I forgot to mention that we do follow families for a year after the death in bereavement, and Irv was very nicely describing that. And the volunteer would follow with the family, initially possibly weekly, after 3 months every other week contact, after 6 months once a month contact, and then at the year anniversary, within the 13th month, we do say goodbye. We also run bereavement support groups 3 times yearly for families. They're 8 sessions each. And we have a chaplain who runs that part of our program now.
So this would be a group that comes together.
Yes.
And I imagine they get some support from each other as well in
Definitely.
that case.
It's made up of our family members, plus those groups are open to community members as well. So for instance, if a patient were not served by hospice, their family member, the survivors, would be eligible for coming to a bereavement support group, and they're publicized in the local papers and the churches and synagogues as well.
Will they find this under the calendar section, perhaps, or
Yes,
something
or
like
in
that?
that little article in the local paper, yes.
How would I look you up in the phone book if I wanted to find you? I mean, are you in the yellow pages under hospice? Is it as easy as that? Or?
We are under the yellow page hospice, under home care agency. I think if you looked in the telephone book, you would find us under either of those. But for anyone who might be interested in the number, and you have an older phone book and it's hospice at home, it's today Hospice Care of Massachusetts, same area code, 443-8150.
And that's right here in Sudbury, then?
Yes, it is. That's our office. However, our work is done
Sure.
in the homes.
Well, I noticed you had a whole lineup of towns that you serve.
We do. We're going beyond the Sudbury area. Wherever we can meet the needs of the patient, we are able to go about a 40-mile radius from the office.
So it would be helpful then to have volunteers in many different towns.
Yes, and that's part of the challenge of my position right now, is to go, for instance, this week I have appointments in Lowell and in Stoughton to try to develop cadres of volunteers in other areas that our admissions counselors are now beginning to attempt to get referrals from. We are also beginning to go into nursing homes. We have contracts with nursing homes for respite care, and we also are looking for referrals and are serving patients in nursing homes. And within that setting, we would also place volunteers to support the nursing staff in the nursing home setting. It's as if the nursing home were the home, the residence. That's how we treat it.
Okay, so you treat it the same way as you
So
would
like
when
we would go into your
a-
home, we would go into a nursing home in the same way.
And the patient in the nursing home setting would be using the Medicare hospice benefit, meaning, by the way, in 1982, the Medicare approved the hospice benefit, and working as a team, and all hospices would have the same guidelines and basically the same philosophy, that the patient is terminal, the patient is looking for palliative care, meaning symptom control rather than a cure.
Would this be my way of saying make her as comfortable as you can for the
Yes.
time?
Yes, comfort measures.
So it's, would you ever take a patient out, for instance, and again, I know it depends on how mobile they can be, but would many of them be in the kind of a situation where you could take them out
yes.
for a lunch, for instance, so they get a break from...
We would encourage it, in
In
fact.
fact, we have a volunteer whose contact with the patient is going to the dump on Saturdays.
Okay. Now, do they meet other people when they're there?
No, but
just
this
a-
is what the need is. And we support the patient as long as he or she can do that in whatever way is possible. And this is the need. You can do a lot driving back and forth to the dump. I know it sounds funny, but
Well, of course,
it's
the dump
really
is
very
always...
special. It's really a very special, and one of the most important components of hospice is the volunteer. It started out historically as a volunteer organization.
I
You
see.
might-
And then it expanded, I suppose, as, our population got older, probably.
Yes, and more professionals got involved. I'd call them professional volunteers, my people.
Yes.
Yes.
Well, this is something people don't always understand about a volunteer, too, is that the demand on the volunteer is just as great as it is on the paid staff, because you rely on them
Sometimes
to
more
be
so.
there and to do what they have said they're going to do.
One thing you haven't asked about yet is reimbursement, and
The
I think
method
that
of
would be, yes,
the-
important.
where does your payment come from on some of
address.
this?
Well, I think one thing to remember is that terminal patients are patients who can be very young. We have had infants, and we have had AIDS patients, so it's non-discriminatory terminal illness. And unlike some of the thinking that hospice care is strictly for cancer patients, that is false, because terminal illness can be any number of diagnoses, such as end-stage cardiac or pulmonary disease or respiratory problems.
And of course, Lou Gehrig's disease, which
Yes, ALS.
seems to be one of the even more debilitating ones.
Very much so,
as,
yes. Reimbursement usually comes from insurance companies. Medicare, for example, would pay 100% for hospice care for patients. All of the services that Liz and I have just described are covered. All members of the hospice team are available to every patient. Some patients or families choose more social service visits, social work visits, and some need more home health aid coverage.
So as a general thing, this would be covered by Medicare?
Yes.
If you're 65 or over, I guess.
That's correct.
Medicaid if you're not, if you're younger, and may not have the resources, I guess.
If people do
And
not
your
have
insurance.
If people do not have a hospice benefit, that is not a deterrent for taking someone into hospice care. we are committed to giving hospice care to patients, regardless of their ability to pay.
We have a fund set aside for free care.
Now, would this be one of the fundraising dimensions then that you have? Is that one of the reasons for your fundraising, is in order to provide some of this care for people who might not otherwise qualify for it under their insurance or not have the resources?
Yes, that would be one of the.
So this would be a tax-deductible donation if anybody...
To the Friends of Hospice Foundation, yes, it's tax deductible.
And how would they get in touch with the Friends of Hospice Foundation now, if somebody were interested?
Well, that would be
in
through the
contributing
number
to
that Mary mentioned.
Okay,
already.
your phone number. Maybe you might tell us again. The number was
443-8150, area code 508.
Okay, so that's really the best number for any kind of information
Yes.
that
Yes,
you have.
it would be.
Irv, do you ever find yourself in what might be called a babysitting situation with some of your patients?
Sure.
That it might just be a matter of coming in and watching TV with them, or just keeping them company.
Yes.
So, now I've also heard that it's harder to get somebody to stay with an older person than a younger person. Do you run into this?
No.
You haven't found any differences.
No. Got a quite young man right now, and an older man.
Now, what are some of the kinds of things you would do with people like this? Would you, for instance, play a game of cribbage? What are some of the experiences you've had? I don't play cribbage.
I might learn how to play cribbage. Almost anything that was appropriate to the person's needs, capacity, or interest. I have to be led by that person. I don't try to lead it.
Do you find that they do that? You know,
Sure.
everybody's a different temperament, and
Sure. Some people want to go shopping.
and they feel well enough to do that, or they're able to get out and around enough to do that.
But I took a man shopping, I guess back in October, and he just couldn't drive his car anymore.
I see, but he could go. Okay, well that would sound
Now, all I did
like a
was
common
drive him,
problem, not
and-
being able to
and
drive.
I
Sure.
walked with him because he's a bit fragile, and I made sure that he got in and out of every place, and it was fun. He was very interesting. I haven't seen him since.
Is he single? I mean,
There is a current patient you have right now who is interesting, and maybe you could tell us a little bit about what you're doing with him if you want.
A youngish man, very bright, very well educated, a scholar. He has researched up and down, back and forth, his disease. He knows as much about, well, he has two diseases. He knows as much about those illnesses as anybody is ever going to know, and he's ready to tell the doctors how to do it. And he does tell
well,
them how
he may
to do
have some good ideas living with it himself.
Well, he's a package. He's a package, all right. Because he's got his own ideas about everything, and he has certainty about everything. I don't have certainty about anything. So we get along fine. But I admire him because he's fighting like a Kilkenny cat. He's fighting for his life every minute.
Yeah, and apparently that makes a big difference too. Is the so-called will to live, I guess, is what accounts for a lot of the miracles that we have. So this man is doing that.
Yes, and
Yeah, excuse me. Well, what's interesting is he is fighting for his life, and he has signed on for Hospice Care of Massachusetts, and we take care of the terminally ill. So we have this juxtaposition of someone who is living really until he dies and making that choice.
Yes, living every moment to it.
Yes.
I admire him I don't like him, but I really admire him.
Well, you know, I hear that once in a while myself. So, so is he single, maybe?
As a matter of fact, he is.
Oh, good. Tell him I asked, and let's see what happens.
But he'd be interested. Absolutely.
I think that's great, though. But I do. I really love to see them when they're just living every minute. And sometimes it's amazing to me the courage a lot of them have, knowing that
Yes.
their time is short. They have different reactions to it, I'm sure. But this guy figures probably he's going to rap on the on the coffin door when they shut it and tell him he's not quite ready to go from
Get away.
Wait a minute, I've got a few more things I want to do yet. So that one of the things that I wondered if anybody gets into is the living will that we hear so much about. And I mention this because periodically we will hear something in the newspapers about a family whose sick member may be in a coma for just years and they're being kept artificially alive. Does this ever come up as a question to you folks?
Most hospice patients choose not to have resuscitative measures or extraordinary life prolongation procedures.
The so-called heroic.
We would call it do not resuscitate order. And patients think about that, and often that is in place
Yes,
when
when
one
they-
becomes a hospice patient. Sometimes there needs to be a little bit of assist with the letting go, that it is okay to pass on to another life, if that's what you believe.
Well, it makes it so much easier on the family left behind not to have to make that decision for it. And it's good if you do have the time. You know, not all of us know when the final day is going to come, but with most hospice patients, I presume they have some kind of an estimated time as to how long they
It is
expect to live.
estimated to within
So
the
that
6
they,
months, usually before one is accepted into hospice.
Well, it's my understanding that Massachusetts does have and accept the living will. So I would suggest to anybody listening that you do talk to a lawyer about it. And most living wills, again, as I understand them, will specify that as far as a trauma after accident is concerned, there will be specialized cases where you say, yes, I want every measure taken to save my life, but when it becomes known that there is no hope of recovery or there is brain damage, for instance, then you can make your wishes known ahead of time and relieve your family of the burden of making that decision at a time when they're going to be a little bit distraught for you. So I guess it comes down to see a lawyer as well as see a doctor when you know that you have an illness coming on. Now, you're going to maintain your status as a volunteer, and you are the director of the volunteers,
Yes.
Elizabeth. And Mary, you would be the person probably who is the first contact
Usually, yes.
that anybody would have
Anyone
if they
can
were
make a
seeking it.
referral to hospice, and I would follow from there.
Okay. And would that happen from a hospital too, or
Hospital,
Or
a
the
home,
individual?
a physician, a discharge planner, a social worker, anyone.
Okay, so somebody who finds that they're in a situation now where they know they have a terminally ill patient, know that they're going to need an assist,
Yes.
and ordinarily would not know where to go, I hope after listening to us today certainly have a good idea of where to start for it. I want to thank the three of you for being here with me today. I think it's an important message that people just don't face up to until the need hits, and then it's most difficult to make that decision. If the time comes, remember what you heard today, because everything we've told you today is for the record. I'm Mary Jane Hillery, signing off.
Channel 5 here. That's 575. that man's car just hit us.
If you or someone you know has been the victim of a drunk driver, call us. We're MAD. We're Mothers Against Drunk Driving. Call 1-800-633-MAD. That's 1-800-633-6233.
Welcome to For the Record. On this show, we talk about events and issues of interest to our local people. Today I have with me Janet Locke. Janet is president of Mothers Against Drunk Driving, the Metro West chapter. And Janet, perhaps we can lead right into it. Maybe you can tell me, how did something like Mothers Against Drunk Driving get started?